Hello, everyone. This is Dr. Isabelle Amigues, your friendly rheumatologist, and we are doing another Rheumatology 101 live about PMR, Polymyalgia Rheumatica. And this came from a recent case I had. It's always really fun, this practice, because I get to see patients much faster than they usually would come in a rheumatology practice normally, right? Because they develop some symptoms and they Google and then they find me and then they come to see me. The truth is that the vast majority of patients with PMR, it actually always surprises me how much time it takes to make the diagnosis. So I'm going to tell you the case and then we're going to, unfold it. So it's the dad of, so it's a granddad even, right? So someone that's over 75 that came in and basically said that, okay, well, 2 weeks ago, woke up, severe pain, couldn't raise my hand because my shoulder were so painful. And then my hands also were painful. And then he developed some pain also of his hips. And we talked about it and he was like, well, actually really what's bothering me is the muscle. It's muscle pain. It's not so much joint, it's muscle pain. And then we started talking, well, can you actually easily shower yourself? Can you comb your hair? It's like, actually, this is really painful. This is really hard for me. I cannot raise my hands. And so on exam, that's exactly what happened. So his blood work basically showed very elevated markers of inflammation. So CRP, SR was high. And we started giving him a very small dose of prednisone and all of his symptoms were gone. I mean, small, it's 15 milligram per day. So it's not small, but it's definitely not super high. What is polymyalgia rheumatica? So PMR is an inflammatory, and we thought that it was an inflammatory arthritis, but more and more, we know that it's also the tendons that are inflamed. The muscles seem to be inflamed as well. So it's not the same than rheumatoid arthritis, where it's really like mainly the joint. In this case, there is involvement in the tendon, the ligament, as well as the muscle. And it affects the girdle, so the shoulders girdle. And it doesn't have to just be the joint. So it can be like the whole neck, the shoulders going down a little bit on the shoulders. Same thing for the hip. It's the side of the hip. It's not so much the inside of the hip, but rather the outside, the lateral aspect of the hip. And it is very inflammatory. So yes, there is definitely, it's worse in the morning. And it's associated with this elevation of inflammatory marker with the CRP that's elevated, the ESR that's elevated, and no other markers. So what I mean by that is that if you check a rheumatoid factor or CCP, that's going to be negative. If you check your uric acid, thinking maybe this is gout. Gout usually doesn't involve the shoulder, by the way, but you're thinking, okay, maybe this is gout. Well, it's not gout. Uric acid would be normal. And then you can also, if you were to do x-rays, you would see nothing on the x-rays, right? Because one of the other possibility would be like, can this be pseudo gout where it's calcium deposit or chondrocalcinosis that's causing the inflammation? And we're not seeing that in PMR. And then the thing that's really typical is when you're giving 15 milligram of prednisone, which in the world of rheumatology, when you have a flare, is not a very high dose. So you give 15 milligram per day of prednisone, and basically the next day, there is no more symptoms. And it's actually a really interesting condition because it is inflammatory. It happens later in life. It never happens before 50 years old. Honestly, in my practice, I've only seen it after 65. I'm sure, there is everything, but you don't make a diagnosis of PMR before 50, that's for sure. It's usually more white people, more Caucasian people, but it can happen in everyone. And then it's associated with this inflammation. The thing that we have to remember is that it's also associated with GCA. So what I mean by that is that when you have PMR, you have to make sure you do not have GCA. GCA, giant cell arteritis, We talked about it last week, so I'm going to refer you to that video. And it's basically headaches, fevers, pain when you're combing your hair, and necrosis of the tongue, cough, basically symptoms that are more systemic and that are not just muscle and joint related, okay? If you have any of those, or like loss of eyesight, that's like a very important one for GCA. If you have that, you have, and maybe you started with PMR symptoms and then you develop the GCA. And so when you have GCA, you look for PMR symptom. When you have PMR, you have to look for GCA symptoms because the treatment is different. PMR, we're going to start with just, prednisone 15 milligram daily. We're going to see if you can potentially get off of it. And if you cannot, we have biologics. They work really well. And they act on the IL-6. And I think I mentioned that for the GCA last time. So it's a very inflammatory, it's an inflammatory process. We know that's caused by too much IL-6. So we stop the IL-6, okay? And then GCA is much, much, much higher dose of prednisone, right? So we would give prednisone 15 milligram daily for PMR. When we are worried about GCA, we're actually going to give 1 milligram per kilogram per day. So it's more like 70, 80 milligram per day of prednisone. So you see that there's such a huge difference. The other thing is PMR, there's not much risk associated with it except for developing GCA. GCA, there's the risk of losing your vision, of having aortic issues, so aortic dissection, aortic problems, right, like chest pain, things like that. So when we have PMR, the way I think about it is that it's a way maybe to prevent further issues. So we're going to prevent GCA from happening. And then there are some studies that are showing that if you have PMR, you're maybe more at risk for having a cancer, that maybe it is considered one of those paraneoplastic syndrome. Para means next to. Neoplastic is, the neoplasm is, it's cancer, right? And so some people think that PMR is a paraneoplastic syndrome in some cases. And so what that means is that if you do develop PMR, we just make sure that you're up to date on your cancer screening. If you're a woman, you've had your mammogram, you've had your colonoscopy for both women and men. For men, that you've had a PSA. And if you are a smoker, or if you've been a smoker for more than 30 years at 1 pack per day, then we also do a low-dose CT of the chest, right? So it's really not that big of a deal, but it's just you have to look for it because that could potentially help you prevent to find a potential cancer at a very late stage when you could actually find it at a very early stage, because it's not because you have a paraneoplastic syndrome that you have a severe cancer. Like, it could just be a very mild, maybe sometimes we even find the paraneoplastic syndrome before there is a cancer that's visible on testing, right? We still think that it's probably there in the blood, but we don't see it in the testing. So you do your cancer screening for the age-appropriate cancer screening, or we look at all of the symptoms you have to make sure that you're doing really, really well, and you have no symptoms except for the PMR symptoms, right? And we can prevent it. And the good news is that it's, I almost want to say that it's easily treatable, right? Because PMR may not stay forever. So that's the good news. And so we try the prednisone. We make sure that you don't get complication from the prednisone use, because as you know, we don't like to keep prednisone on for a long time. And then we back off. We see if you're developing symptoms. Some of them are just looking at the ESR and the CRP, so the marker of inflammation. Are they coming back up? If they are coming back up, then you have to try again, to go back on the prednisone, try again. And if after, usually second or third trial, you say, okay, this is not working, you're dependent on prednisone, let's put you on one of the IL-6 receptor agonists, such as Kevzara, or so Kevzara is the one that's approved for PMR, I wouldn't be surprised if tocilizumab gets approved. It's literally very similar. And so that's what we are doing basically for patients with PMR, and it works really well. And then same thing, after 6 months, you can try to decrease the Kevzara and see, right? Like, I don't think that there's studies yet on tapering off Kevzara. The truth is that from a pharmaceutical drug company perspective, I would say that it doesn't really make sense for them to do those studies, since they get more money if you put on that medication forever, right? But you try. It's always a trial and error thing. You try to back off from the drugs, and usually you can see pretty easily, is it coming back up? Is the ESR-CRP coming back up? Are your symptoms coming back up? And then the last thing about PMR is that sometimes it can actually be the presentation of actually rheumatoid arthritis. So sometimes I'm not completely sure if it's PMR with rheumatoid arthritis, or if it's PMR, and we have CCP rheumatoid factor that are positive, and they are just like that, or if it's just the presentation of RA as PMR. The good news is that it doesn't really make a huge difference. I would say that if you have positive CCP rheumatoid factor, make sure that you don't have any joint issues of your hands and feet, because that's usually where RA starts. And then if your symptoms are more PMR, I personally would treat it more like PMR, and I would put biologics like Kevzara, because it also works for RA. So it's a non-problem, right? And then you just keep yourself open to the possibility that it's going to evolve into an RA, and all of the prevention of complication of RA as well. But I would also think of GCA as well if you were to have headaches and all this, right? This is really where it's an art. But I think it's important for everyone that has the symptoms to learn about them and to understand how they can be, how they can present and how they can be related. I think that's a lot for today. Just think, when you're thinking PMR, think GCA, so think headaches, fever, pain in your scalp. And then I'll see you next week. If you have any questions, if you're watching this, hashtag replay, if you're watching this right now, put live, hashtag live. Hi, Dawn. Hi, Garces. Hi, Nicole. Hi, Fatane. Hi, Jill. Hi, Steph. Hi, Heather. So many people have joined today. I don't actually see the name of the YouTube people who are in, but hi, everyone. I'm sure Rockdoc is going to be here, if not today, a little bit later. And I will see you next week. Thank you, everyone, for watching. It's always a pleasure. Share this with someone if you think that they will like it. Take care. Bye-bye.